Good afternoon, ladies and gentlemen. Nice to be here. I'm Glenn Tang. I help manage our pediatric anesthesia subsection of our anesthesia group, and many of you know me, and I know many of you. And for those who don't, it's my pleasure to meet you, and hopefully we'll get to work with each other a lot. I have a kind of a wide-ranging topic today, and it's about the care of the pediatric PACU patient. I'm not going to talk about specific anesthesia drugs today, but more general overview of how the approach to taking care of the post-operative pediatric patient. First of all, we need to see a cute slide. Okay, this is illustrative of the airway of an infant. You can see the infant's tongue is relatively large in proportion to the rest of the mouth, rest of the oral cavity. And because of that, under anesthesia, more prone to airway obstruction. First lesson, okay? The larynx is higher in the neck, and I think later on you'll see a slide that illustrates that. More anterior located, or superior, as we say. Also, we have, in children, narrower, stiffer, more floppy epiglottis. Making intubation slightly more challenging to those people who haven't intubated babies before. This is another cute slide, and this basically shows that because the large occiput of a baby, just lying the patient flat already brings the baby into a relative hyperflexion. So you have to extend the neck a bit to open the airway. And certainly this is what we do. When we put the patient to sleep, we usually put either our hand is on the neck, on the head to kind of extend, or as this slide illustrates, you roll a little, you put a little roll under the shoulders to take that neck out of flexion and align the plane so that you can have a freer airway, more open airway, and so that you can intubate more easily. This slide also talks a bit about the differences between the pediatric and the adult airway, and we've already talked about the fact that the tongue is larger, the pharynx is smaller relative to the adult. You have a floppy epiglottis that is hard to control and intubate. The larynx is more anterior and superior. And unlike the adults, where the narrowest portion of the airway is the vocal cords, where the rima glottis, the opening of the trachea, in the infant, the narrowest portion is the cricoid. Okay, the cricoid is the only complete ring of the trachea. It's a cartilaginous ring that is a total ring, and so not expandable. So you can imagine when you have a tube down the trachea, in the adult, the narrowest portion is the opening of the cords, but in the kid, it's subglottic. So even though the ET tube may advance easily through the tube, further down at the subglottic level, the tube may be actually compressing the airway. So therefore, you do not want a very tight airway. Therefore, in infants, anesthesiologists will, after they intubate, will check the leak. So you want some leak. Okay? If there's no leak, then maybe it's too tight. And the only take-home lesson is that if children who have been intubated with too large ET tube, or children who have some swelling there already from a cold, they can manifest itself in the PACU with croupy cough or stridor or something like that, okay? And we'll talk about that more. Now, some general principles. I think these are general principles. If some of these are not what we practice, stop me right away. But generally, all pediatric patients are admittable to PACU in this hospital, okay, even the newborn. Now, if they weren't healthy or if they were sick, we wouldn't send them to the PACU. We would make decision to go to PICU or something like that. So, but usually, if they're healthy, even newborns can go to the PACU. Okay, we encourage parental presence in the PACU. As soon as the patient is in the PACU and you're comfortable, you've taken a set of vitals, do invite the parent to come in, or one parent at least. Like I said before, the anesthesiologist before the meeting will not abandon you with an unstable child, okay? And call for help if you need it. Now this is a worthy slide, but all it says is initially when the patient comes in, one-on-one care is expected. And then once you're comfortable, or patient is well, or not sick, or not unstable, then you can take care of more than one patient. Sometimes 1 to 2, I don't know, sometimes maybe 1 to 3, but 1 to 2 probably. You need to be flexible and aware and understand the common problems that can happen in the pediatric age group. Naturally, all the beds need monitoring equipment and equipment to deal with the most common difficulties, including bag and masks of various sizes, airway resuscitation equipment, a crash cart. All these things, goes without saying, and that's what we need, and that's what we have. We have a program in Cedars called the Pediatric Champions. I think some of you know about it. And that means that every every PACU has a designated pediatric resource person, usually a CN4. Am I correct? Right. And in addition to that, we instituted last year some sort of experiential exposure for PACU nurses to come into 3 OR to have some hands-on bag and mask experience. Okay, we can't invite everyone at a time, so it's a few at a time. And are we still doing that, Val? Yeah. Okay. So that's good. Our intention is that you not learn how to intubate, but under the direct supervision of an anesthesiologist, get comfortable with masking a patient a little bit at least with a bag and mask, basically, and positioning, jaw thrust, chin lift, the usual positioning maneuvers that you need to handle the airway. And of course, there's this ongoing educational program which you guys have, and we participate once in a while, occasionally by giving you lectures and in-services. So, okay, assessment of pediatric post-op patient. You need to know a few things. You need to listen for the anesthesiologist's report. Some of us give a better report, some of us give not as meaty a report, but you need to be comfortable with what we are giving you, and if you have any questions, you need to ask. You need to appreciate the interruptive course of events that happen to your patient. You need to appreciate some of the anesthetic effects of the drugs. You need to use your senses, which I think probably is the most important thing for a PACU nurse. I mean, all your senses take care of your patient. You need to, and maybe close second, is you need to know the pediatric normals. Okay, the normals of adults are completely different. And I think last year or a couple of years ago, we instituted a program whereby your PACU nurses received a laminated card with some of the normals, and that may be something easy to refer to, okay? And like I said before, you need to know some of the common PACU complications and have a low level of suspicion for it as they develop, and they do. On arrival to the PACU, my belief that patients should be transported with oxygen. I think if some amount of time has relapsed in the OR and the patient's wide awake and saturating above 95%, perhaps not, but in most sleepy patients coming out of OR, they have a chance to hypoventilate, have desaturation. So it's my opinion that everyone should be transported with oxygen. And certainly when they arrive to you, put some oxygen on. I've seen some nurses, I'm not sure why, but maybe it's sort of, they think that the faster they get the oxygen, the better off. So I think err on the side of keeping the oxygen mask a bit longer rather than a bit shorter. If the patient pulls it off, and awake enough to take it off, then take it off. But certainly, once in the PACU, children should receive oxygen by mouth or blow-by. Okay. On arrival to the PACU, you need to confirm the patency of the patient's airway. You need to assess for the adequacy of ventilation. That means the patient's breathing. You need to assess the adequacy of perfusion. That means there's a blood pressure. You need to assess his or her baseline mental status or CNS function. And you need to get a comfort level for a return of protective reflexes. And we'll talk about these. Now, protective reflexes are, and many of you know this inherently or because you work with patients a lot, but let's just talk about them. The protective reflex basically is the ability to prevent airway obstruction from your tongue falling back, from the soft tissue of your neck, kind of stopping you from breathing. From the under anesthesia, everything loses tone. So the epiglottis, soft tissue, soft palate collapses. There are more secretions. All these things retard normal ventilation. Protective reflexes is also the ability to cough and to spit out tracheobronchial secretions, to expel them. Okay. And also return of reflexes that maintain your perfusion, and we call them baroreceptor reflexes. That means basically if you're if you're hypovolemic, you get a little tachycardic, or you know what I mean. Your body tries to maintain blood pressure basically. So you need to be able to assess that patient is able to do some of that. Chemoreceptive reflexes are patients' response to hypercarbia, which is an increase in CO2, or hypoxemia, which is a drop in O2. Patients should be able to increase their ventilation in response to these things, okay? And you should be able to see it. Vital signs that we monitor go without saying. Heart rate, blood pressure, oxygen saturation, respiratory rate, temperature, and of course, pain level. And that's very, very high on our list of things to watch out for too. Okay? Now, I think here we use 1 to 10, but this is the FACES pain scale. And children sometimes may or may not be able to tell you how painful, how much in pain they are. If they're babies, they certainly can't. And those who are parents, maybe, we think that we can recognize a painful cry, which is different. But, sometimes they're under anesthesia, or they can't speak, or they can't tell you. So one technique is to, we ask the patient, does it hurt? Point to where it hurts. And in younger toddlers, you can tell them, okay, it's your pain. Does it feel like this, or does it this? And so you have a way of assessing pain and following pain. The anesthesiologist report. The anesthesiologist should be able to tell you the patient's medical condition, any special problems related to the underlying illness, what happened during surgery, any complications during surgery, what kind of techniques did he use, general, MAC, spinal, local, what medications were given, any problems that were encountered intraoperatively, and maybe even alert you to any possible problems which could happen in the PACU. That would be a good report. The anesthesiologist, as far as telling you a bit about the patient's condition, this has to do with telling you about the pre-op vitals, developmental status, is the development delayed, what are the current medical problems, autism, diabetes, mental retardation. You don't see that much hypertension, but in renal patient, hypertension, what kind of syndromes the patient has. And now, we see, one of the distinguishing things about pediatric anesthesia is that we deal with a lot with syndromes. And the anesthesiologist should be able to tell you what kind of syndromes the patient has and what the effects are under anesthesia and what you can be expected to have to watch out for. And past medical history, medications, and allergies. We've talked about some of this, special problems, developmental delay, syndromes that predispose to airway obstruction. We see quite a few of those kind of things across the street, in fact, even in 310 when we do with plastic cases, a cleft palate, or Treacher-Collins disease, or these kids with airway syndromes that have microtia and have their ear reconstructed. So there are a lot of airway, a lot of syndromes that predispose to airway obstruction that you should be aware of at least, or at least hear about. Obstructive sleep apnea. Any child with severe obstructive sleep apnea or significant will not be done as an outpatient. It will be done here. And in preemies, you have consideration of apnea prematurity. And we'll talk a bit more about that. Congenital heart diseases and whether this patient is on a home vent. These are some of the abnormal airway syndromes or disorders or that have anesthetic complications afterwards, or could have anesthetic considerations at least. Congenital neck masses, anomalies, syndromes, inflammatory processes, foreign body in the airway, metabolic diseases. I'll just talk about one, the Treacher Collins. And the reason why I brought that up is Dr. Reinisch, Dr. Lewin, we do a lot of their ear reconstructions across the street. But then the children with bad Treacher Collins, they're done here because of the airways. Let me see. Oh, I don't have that picture. I was going to show you. This is my other slide. Anyway, the Treacher Collins baby, child, they have underdeveloped faces, very micrognathic jaws and chin. And in those type of cases, you can imagine that they would record, they are prone to airway obstruction because their tongue is kind of pulled back. So knowing this, the anesthesiologist will tell you, watch out for this, or maybe keep the patient on the side, keep the oral airway in until the patient is fully awake, things like that. Okay. The anesthesiologist report not only tells you a bit about what happens in the OR, but should have some red flags if you hear of some of these clinical events happening. Like, for example, you should a red flag should be waving your eye, or at least some amber alerts when there's a long case in a small child, or a big tumor in a small child, or an open abdominal procedure in a long procedure over 3 hours in a small child. For example, a Wilms tumor, excision. Laparoscopic procedures, long laparoscopic procedures in a small child, or open thoracotomy in a small child. All these should say, okay, this is not a normal patient, and you should sort of even have 110% alertness on these kind of patients. And of course, the anesthesiologist also should tell you the estimated blood loss. A bit about the anesthetic technique. Anesthesia, I tell in residents, is kind of like soup. It's a little bit of this, a little bit of that, and together you have this delicious potion. But anesthesia is the same way. I mean, there's a pre-nap medication, there's the actual anesthetic agent that's keeping you asleep, neuromuscular blockade, which keeps the patient still and needs to be reversed at the end of the case before full return of muscle strength. Analgesics, blocks, regional airway, and also the way you manage the airway. All these drugs, they don't just come and go. They have a natural half-life, and when the child comes to you in the PACU, these are all on board still. They don't just disappear. And you have to deal with the tail ends. And as the anesthesiologist, I kind of plan my anesthesia so that when the patient comes to you, should be well on the way to recovering. But some of these effects are still there. The inhalational agents are still making them sleepy. In some respects, maybe some patients are not adequately reversed and from a muscle relaxation and will be weak. So you have to know that this is on board and this can happen. Any intraoperative problems, difficult IV access, difficult mask ventilation, difficult intubation, any hemodynamic instabilities, greater blood loss than expected, and by this I mean more than like 10% of the blood volume. Things like that are indicative of intraoperative problems, which unfortunately everything that happens in the OR you have to deal with in the PACU. So knowing these will help you understand what could happen to your patient and how to treat them better. So using your senses is very important for a PACU nurse. In fact, observing a patient is the most important monitoring modality. Use all your senses: sight, touch, hearing, and common sense. Sight. By sight, I mean an experienced PACU nurse should be able to assess the patient in like a few minutes, know like how the patient's doing, okay? And that not just hocus pocus, but that means putting down the monitors, looking at the vital signs, making an assessment, looking at the color of the lips, watching for signs of hypovolemia, watching for how awake or restless the patient is, breathing pattern, adequacy of ventilation, what is the respiratory rate, is the patient moving properly, or is he like a fish out of water, and that means indicative of maybe some muscle, residual muscle paralysis or weakening. How is the patient emerging from anesthesia? Is there emergent delirium? Is this right? Is this normal? Whether the patient is feeling pain and grimacing. Touch is very important first. Touch, basically, I'm referring to as whether the patient, what's the temperature, and what's the perfusion. The greater the core and to skin gradient, the worse the perfusion. I mean, patients that perfusing well should have very little gradient between a core and skin temperature. And knowing that, and if there's if they both are low, it's probably you have a hypothermic patient. What are the signs of hypovolemia? I think this is really important for PACU nurses to understand. And it's not just about a blood pressure. Patient can display cloudy sensorium or unresponsiveness, dry lips and mouth, sunken, reduced skin turgor, flat fontanelles for babies, or flatness around the eyes, crying without tears, tachycardia, of course, or weak distal pulses, poor mortal capillary refill, sluggish respirations, and of course hypotension and poor urine output. All these are signs of hypovolemia, which you should know by second nature. Using your senses again, hearing. And by this I mean, how is he breathing? Is he, first of all, how is he breathing? Is there noisy breathing? And noisy breathing is sort of this funny term, but actually, if there's noisy breathing in the PACU, you need to like prove that the patient is breathing well before you think it's just not important. By noisy breathing, I mean, is there stridor? And that's like an inspiratory, like that, okay? That's wheezing, which is an expiratory sound. That happens in asthmatics or patients with bronchial problems or reactive airways. Post-extubation croup, and some people call it post-intubation croup. And this was referring to my first slide with, was there maybe too tight a tube? Is there some airway edema in the trachea? Is there airway obstruction? And hearing also has to do with whether the patient is crying, and that has to do with is the patient in pain? Do I need to treat his pain? And emergent delirium, agitation. I was in 310 the other day, and this patient was screaming, and the father was so upset because and I had to ask the parent to actually leave for a few minutes so I can take care of this patient, because this was what we call pure emergent delirium. I mean, there could have been pain, but this procedure wasn't that painful, but it was a 16-year-old girl that was just out of control, and you'll see that in the PACU, especially with these shorter acting inhalational and anesthetic agents. And those need to be there's a way to treat them, and not to be too uptight and too upset. Unfortunately, with patients right next to each other, everybody wants to take care of these patients very fast, and we do. Common sense is a critical combination of knowledge, experience, and intuition, and I think that this comes a lot of it with experience, and the experienced PACU nurses, I don't think that they all immediately have common sense, but it comes with partly with practice, partly with knowing your normals, partly with compassion and knowledge, experience, and intuition. Now, the next segment of our conversation is about knowing your normals. I'm not going to, just read through every normal. I think the take-home lesson is that taking care of pediatric patients is different from it's not a small adult. A pediatric patient is not a shrunken small adult. Everything is slightly different, okay? And one big area is the normals. And knowing what your normals are will equip you with not freaking out in one hand, and on the other hand, with knowing when to be worried, knowing when to be, genuinely concerned. Normal heart rate. Just talk about it real quick. Newborns to 3 months have a higher mean heart rate in the hundreds, 120, 140, normal. That's normal. As in infants, as they get a little older, it drops a little bit. Not much, but it drops a little bit. And once you get to toddler age, to 10 years of age, it drops even further, and until you're around 10 or 11 years old, when you're kind of like an adult, 75 beats per minute or so. Okay. So tachycardia is normal in a baby, but bradycardia is not. Okay, and we'll talk about that next. There are also normal blood pressures. A newborn can be in the 60s systolic, and that's normal. Or if you're preemie, you can be in the 50s systolic, and that's normal. So you just have to know where they should be, and if you need to refer to your little card, that's okay. That's okay. Definition of hypotension is important. Term, we say less than 60 systolic. 1 year, about less than 70 systolic. And in the childhood ages of 1 to 10, from this PALS manual, 70 plus the age times 2. That's something, do I make this calculation every time I have a patient? No. I mean, I don't really calculate it, but because from my experience, I kind of know where they are. But if this helps you kind of get a ballpark, make the calculation. And of course, after 10 years of age, less than 90 is what we usually consider hypotension. Like in the adult patient, less than 90 is when we usually would treat something. And in teenagers, that would be this case too. Respiratory rate, also different. Neonates, infants, toddlers, faster respiratory rate. Okay? That's normal for them. But when they get back to adult school age, it's around 12 to 18 so per minute. That's normal also. A respiratory rate greater than 60 is always abnormal, and it's a red flag. Okay, so is slow breathing or irregular breathing in an acutely ill infant or child. This is an ominous sign because it often signals impending arrest. Now, if I were to give you a quiz, say these are the vital signs quiz. I'll give you a quiz now, but I'll give you the answer too. All of these are concerning, and whenever just think about it when I tell you, like too fast a heart rate or too slow heart rate in newborns, bad. Okay, croupy, noisy breathing, or any kind of noisy breathing should be concerning at least. Okay, should prompt you to check whether something is going on. I think I'll just go past this slide. Let's talk about some PACU problems in the remaining time that we have. Okay, emergent delirium. We talked about that for a second earlier. That is concerning because you have this child who's like kicking and screaming, but and as I said, oftentimes pure emergent delirium is oftentimes due to the newer inhalation agents, which are fast in and fast out. So the anesthesia comes out really fast, and in some patients, this causes some emergent delirium. However, don't say, oh, that's emergent delirium right away. Rule out what is important first, because it can be other things that are more serious. For instance, hypoxemia or hypercarbia, hypotension, inadequate perfusion, metabolic imbalances, even increased ICP. All these can cause changes in the mental status, in some cases, in very agitated patients. So don't write it off completely, but rule it out, and then take care of the emergent delirium. And also ask yourself, does this patient have untreated pain? Maybe that's what's causing the problem. The treatment of emergent delirium is usually, it varies from anesthesiologist to anesthesiologist, but flumazenil is actually a reversing agent of Versed. You could give flumazenil. Most times people don't, but you could. And a lot of times, a lot of TLC, tender loving care helps. Some of us will give a little propofol, just a touch propofol, not enough to give a lot of return of general anesthesia, but a touch of anesthesia, of sedation, so that the patient kind of falls asleep. And I'm sure some of you have told this patient to your parents before. We try not to wake up the patient, let the patient sleep, and the next time the patient wakes up, the patient will be more calm. And how many of you told your parents that? In a way, it's the same thing. If patients sleep and kind of recover from the anesthetic effects and let it wear off, so to speak, they have less of this emergent delirium. And so that's why we give a little propofol sometimes in the PACU. I don't like to give propofol in the recovery room because it's almost like putting the patient back to sleep. But sometimes in severe emergent delirium, I do. And opioids in midazolam is also, sometimes I do that too. Now, an unresponsive patient in PACU is not a good thing completely. You can have a sleepy patient, but patient should be a bit responsive by the time I bring my patient to you, okay? And you need to rule out whether other bad things are happening, including hypoxemia. And all these things kind of come up because they all have, oftentimes they all have like common pathways towards the end. But you need to rule out hypoxemia, hypercarbia, hypovolemia, hypoglycemia, residual anesthetics and opioids, residual neuromuscular block, increased intracranial pressures, water and electrolyte imbalance, and post-ictal state, that the patients have a seizure. All these can cause patients to be unresponsive in the PACU. The most common problem in pediatric patients, post-PACU, is probably, or at least most important problem, is probably respiratory issues. Hypoxemia, and the three most common respiratory problems are hypoxemia, hypoventilation, upper airway obstruction. Makes sense, right? You need to know that, flat, cold. And other respiratory problems are inadequate respiratory effort, post-intubation or extubation croup, laryngospasm, bronchospasm. And we'll talk about some of these. Respiratory problems may present with the obvious signs of difficulty breathing, but may also present as anxiety, unresponsiveness, tachycardia, bradycardia, arrhythmia, seizures, and cardiac arrest. How do you treat upper airway obstruction? This is like BLS, right? The most important thing a PACU nurse has to do is treat upper airway obstruction. One of the most important. There are a lot of important things, but one of the most. And first of all, check whether the airway is patent. Is the patient obstructing? Is the neck too flex? Is the patient's saturation dropping? You put your hand in is the chest moving? Is the ICC exchanging? Can you feel breath coming? Is the patient breathing? Check for the patency of the airway. And you may need to stimulate the patient. Babies sometimes will or any kind of, even adults, you stimulate the patient to get them to breathe sometime. Reposition. Sometimes they have to be on their sides if they're really sleepy, so that the tongue doesn't fall back. Sometimes you have to, especially for these babies with the big occiputs, you have to put some shoulder roll on the back. Chin lift and jaw thrust, the basic airway maneuvers which all of us need to know. And that's why one of the reasons we're calling you to come to the 3OR once in a while. But I know all of you know this. Placement of oral airways. just because the patient has the oral airway, don't take it out right away. If the patient is awake enough to spit it out or pull it out, yes, then take it out. But otherwise, leave it in there. That's the reason why the anesthesiologist put it there, and it could be to open up the airway. Suction out secretions. Put an oxygen mask on. And obviously, if you need to, positive pressure bag and mask ventilation. Okay, a word about post-intubation croup or post-extubation croup, depending on how you want to look at it. This is a bark-like cough. Have you heard this? It's like like a seal, like a bark-like cough, and it's not just in infectious disease, but in the PACU, it occurs when you have like a traumatic or repeated intubations. Maybe it was a difficult intubation. There was a lot of trials or whatever, or a tight ET tube, so to speak. Longer surgeries, head and neck surgeries, even the trisomy 21 down support has a higher incidence of post-intubation croup. And the treatment of this usually is moist O2 first, nebulized oxygen, humidified air, Decadron, and if necessary, racemic epi. And this is just a dosage of racemic epi that the anesthesiologist will write for. Racemic epi is not just for croup, but maybe even for any kind of edema in airway, and it may be also for stridor. Okay. Laryngospasm. Laryngospasm. How many of you have seen laryngospasm in the PACU? It's hard to see what it is. In the OR, we can tell it because what happens is you can't mask the patient. Normally, if the patient's relaxed or you put oral airway, if the patient completely relaxed, meaning muscle relaxation, they won't have laryngospasm because the cords will open up. But as the patient's going to sleep or waking up, this can happen, and that's when the cords are closed, basically. You have an increased relative risk when you have a upper respiratory infection, younger age, and when you have like airway surgeries. And what happens is the patient's trying to breathe, but the cords are closed, the larynx is closed, so it can't pull in air. The initial treatment is a jaw thrust and a chin lift, and then application of an oxygen mask. When we teach our residents to treat this, we always tell them, okay, you need to put your hand on the bag, on the mask, a tight mask. Okay, what you're trying to do is a lot of times the cords are not completely closed. Usually in laryngospasm, you have a little bit of space between the cords. Okay, sometimes it's completely closed, but most of the times it's not completely closed. And what we try to do is that tight face seal. And in the PACU, it's harder to make a tight face seal because you need to have a ambu bag that will let you do that. But if you can squeeze a little oxygen while this patient has laryngospasm, the laryngospasm will resolve by itself usually, and then the patient will squeeze in a little oxygen and will be able to make it through this episode. And that's why we apply continuous positive pressure. Now, while this is all happening, the saturation is dropping, and lower and lower, and maybe you can treat it with a mask, but sometimes the saturation is so low, and then that you have to treat it some other means, and we don't wait too long before we do that. And what we do is we use muscle relaxation. Now, if the patient is an IV, easy. You can even deepen the anesthetic, or you can give a muscle relaxation that way. But if the patient, and the treatment usually is succinylcholine, because succinylcholine works very, very fast. Now, if the patient doesn't have an IV, succinylcholine can be given IM with atropine, okay? And that will break, quote unquote, break the laryngospasm. So, first thing to do, reposition the head. Reposition the jaw, do a jaw thrust, chin lift, tight oxygen, positive pressure, squeeze the oxygen 100% O2. And if that doesn't work, if that persists, IV succinylcholine. And that is also for a treatment in the PACU. Okay? It may or may not require reintubation. And oftentimes what triggers laryngospasm is also important because what triggers is secretions in the back of the throat or noxious stimulation. That's why when I'm waking up the patient, I try to ask the OR to be quiet. I try not to have a lot of times the OR nurse is trying to clean the patient, clean the betadine off, and they will use like cold solution on, and all that is also a noxious stimulus, and that alone can trigger a laryngospasm. A lot of and laryngospasm doesn't happen in adults as much, but in the young kids it can. And it's one of the dreaded things because they can get away from you if you don't treat it properly. And certainly, if you don't treat it properly, you can have you can have respiratory arrest and cardiac arrest. Bronchospasm, okay, increased risk. We all know it. Asthmatics, kids with URI within the last 4 to 6 weeks. That's why we say. That's one of the reasons why we say your airway is more reactive if you have a cold. So if you had a recent cold, if it's an elective procedure, maybe you should wait. Now, certainly if you're sick. Now, having said that, I mean, certainly if you have a fever or purulent discharge, you should stop. You should postpone your surgery. But kids are always sick. My 3 kids are sick right now, and I'm like still recovering. You can hear it. So that sometimes we don't have that window of opportunity to have them completely well. So as far away from the 4 to 6 weeks from the last URI, the better. Okay. Now, if I'm having a child with asthma who had a recent cough, a recent cold, that I probably will postpone the case. But say the child doesn't have asthma and just had a recent cold, then I might change my anesthetic a little bit and avoid an intubation. The intubation will, stimulate the lower airways and could trigger bronchospasm. But if I can prevent, if I could not intubate, maybe I can prevent it. It's not 100%, but it's less triggering, less trigger for bronchospasm. Apnea prematurity. Let's see. We do preemies here. Most of the times, the sick preemies will not go to the PACU. Most of the time, the sick preemies will go straight to the ICU. But sometimes, what happens is you have an ex-preemie, and whenever you hear of an ex-preemie coming to you, you should immediately ask yourself a few questions. First of all, is it appropriate to do ex-preemie? Is it appropriate to do it as an this question is not really something that you will ask, but say I booked a ex-preemie. Not all ex-preemies are appropriate to do as an outpatient basis, okay? But they could come to you in the they may not be so sick that they go straight to the PICU, but they will still come to you. And the take-home lessons, ex-preemies have a whole bunch of medical problems. But when it comes to apnea and prematurity, former preemies undergoing GA, general anesthesia, may be at risk for apnea, and that's what we're concerned about. Apnea means cessation breathing, right? Post-op apnea is strongly related, inversely related to gestational age and post-conceptual age. Okay? Does anyone understand the idea of post-conceptual age? That's 40 weeks is when you're born. So post-conceptual age is, anytime before or after that, basically. And a lot of preemies are born at 20-something post-conceptual age, And the lower your post-conceptual age and your gestation age, the higher your risk for post-op apnea. The further out you get from your prematurity, the less prone you are or at risk you are to apnea, to having apnea. It's associated with a previous history of apnea as well as anemia. The following are kind of our group's recommendations as far as doing these kids. Former preemies less than 50 weeks post-conceptual age should be admitted after general anesthesia. So if you take care, and you take care of these, and if the anesthesiologist or the surgeon says, oh, this patient is going home. And when you calculate, he's still within 50 weeks. And then we're talking about premature baby. We're not talking about normal babies, normal born babies without prematurity. Full-term babies, these rules do not apply. These guidelines do not apply. Newborn babies do not apply. This is a premature baby, okay, less than 32 weeks. So former preemies less than 50 post-conceptual age should be admitted, okay? And if you ask us, they will not be done at 310 because we know they're going to be admitted. So less than 50 will not be done as an outpatient. Okay? Former preemies who manifest apnea in the PACU should be admitted too. I mean, if your preemie is even outside this 50 weeks post-conceptual age and is showing apnea in front of you, probably should be admitted. And you should probably consider admission for infants near 50 weeks post-conceptual age who are of low estimated gestational age when they were born. Consider admission for any former preemie with a significant comorbidity, regardless of the post-conceptual age. Say you have this preemie who has bad bronchopulmonary dysplasia, or has bleeding, severe hydrocephalus, but it's outside 50 weeks technically. Maybe those kind of patients should be considered for admission too. And admitted patients must have apnea monitoring with pulse oximetry. That goes without saying. Okay. Bradycardia, very, very important. The most common cause of bradycardia, and that must be ruled out first, is hypoxemia. Most bradycardia in infants is a respiratory etiology. Okay. Bradycardia is associated with decreases in the cardiac output, and I always tell my residents the next rhythm that happens after bradycardia is asystole. Okay, that means that you need to jump on bradycardia and treat it, because sustained bradycardia is not good for the patient. I mean, that means you have less cardiac output, progressive metabolic acidosis, and lack of perfusion, and eventually asystole. So it requires immediate attention. Whereas that's not the case in even teenagers or older children. But in young infants especially, it's very important to treat immediately. But it may also reflect vagal responses to various stimuli. Say and you've seen it. You put the NG tube in or something like that, or in the OR we see it oftentimes with, when they do laparoscopic procedures, whatever, and they put CO2, and sudden changes can also elicit vagal stimulation and cause bradycardia. It may accompany increased intracranial pressure. Excuse me. Treatment of bradycardia. Always treat the underlying cause. And if it's impaired ventilation and not breathing well, then treat that. The first initial treatment is oxygen administration, ensuring the patency of the airway, and then, if necessary, positive pressure bag and mask ventilation. Bradycardia should not be treated pharmacologically right away. Treat respiration first and oxygen, and then think about giving maybe atropine or epinephrine. Okay, I mean, if you have a very severely bradycardic baby, maybe you need to go to epinephrine as a close second. But by then it's kind of ACLS already. Okay, and chest compressions. I mean, if you have this patient that is a baby whose heart rate is 32 or 40, you better start chest compressions at the same time you're giving bag and mask ventilation. Okay. Okay, so bradycardia in newborns and infants must be treated immediately. Less than 100 heart rate needs oxygen or blow-by mask. Less than 80 needs positive pressure ventilation and bag and mask. Consider CPR. Less than 60 definitely needs CPR and probably some epinephrine or atropine. So everyone got that? Okay. Next problem, very common also, is hypotension. Now, recently, I guess a few years ago, there was a patient that brought to the ICU, the PACU, that kind of lingered there it was a young age patient, lingered there for a while, and the PACU nurses, I guess it wasn't, the surgeons kept coming back and forth because PACU kind of knew something was going on. I don't know the whole story, but basically, long story short is there was a kind of prolonged course in treating this child with hypotension. Partly was, they were maybe not understanding the normals. Partly with patient, I don't know, whatever it was, but there was a slight delay in jumping on the treatment of hypotension. And so I think we need to remind ourselves, first of all, what the normals are, and having a high index of suspicion that something is going on, okay? I think also in this case, the nurse may have kind of sat on it for longer than he or she should have. That particular case I'm thinking of. Now, hypotension, besides knowing the normal, you have got to have the right cuff. If you have an inappropriately sized cuff, then it could be either high or low, and you know that, okay? The most common cause of hypotension in children is, however, hypovolemia. Okay? Because children can keep their blood pressure for a while, and hypotension is a late sign of hypovolemia in the children. Okay? If you're seeing hypotension in a child, it's a late sign. Hypovolemia may result from an inadequate replacement of blood and fluids lost during the surgery, or even ongoing blood loss. It may be caused by anything interfering with venous return to the heart. It may be caused by anesthetic agents, opioids. Whenever I give fentanyl, or like, a lot of times you say, "Oh, do you have any more fentanyl left, doc? Give him something," and then we give it, and most times that's fine. But if you give a little too much, you see hypotension, even and usually with a little volume, you can take care of it. But certainly, ongoing or residual effects of the anesthetic agents, medications, and drug interactions can cause hypotension. It can also be caused by regional blockade. Those of you who take care of patients who have had blocks, high spinal, epidurals, they can cause vasodilation and cause hypotension. And in older patients, it can be caused by myocardial ischemia and myocardial depression, or even young patients who are septic or have low reserve. Hypovolemia, 95% of children over 1 year of age have a systolic blood pressure of over 80. And in early shock, arterial blood pressure can remain stable until 20% of the blood volume is lost. So in other words, as I mentioned before, hypotension may be a late sign of shock. Now, how to treat hypotension? This is also basic for all of you to know. It's fluid resuscitation. First thing, open up. And whenever you have a problem, put the mask on, 100% O2, and open up the IV fluid, right? That treats, at least initially, a lot of stuff that you have to deal with. The initial fluid is crystalloid, usually, meaning either LR or normal saline or any balanced salt solution. And we usually say 10 to 20 cc's per kilo 10 to 20 cc's per kilo bolus. Right? So if your child is 10 kilos, so initially you would give like 100 cc's, 100 to 200 cc's to resuscitate the child. And you repeat the crystalloid bolus until there's no initial rapid return of the blood pressure. If you need to give blood, type specific blood, also in the aliquot of like 10 to 20 cc's per kilo. If you don't have the type specific blood, then just type O Rh negative blood is permissible to save your patient's life. Okay, consider diagnostic studies. when the first case I mean the case I talked to you about initially about that patient who was kind of languishing in the PACU, and I think one of the things that if I remember, there was not nobody checked the labs, and just because patients in the PACU doesn't mean you can't ask for labs, and patient may not have an arterial line, but you can draw blood. You can draw blood. You can ask the doctor, hey, maybe we should check a H&H, to check or maybe we should check a gas. And if you can't do it, anesthesiologist can, or somebody can draw the lab, and it will give you very valuable. It could give you very valuable information to treat your patient. And I think if I'm not correct, this patient might have been treated faster if a lab was drawn and said, oh wow, it's that low, then she's getting anemic. Just because your last H&H in the OR was normal doesn't mean it hasn't dropped. The patient may have ongoing blood loss that is obvious to you or maybe not obvious to you. Okay, pain. Untreated pain is unacceptable. Every child leaving the PACU should have a pain score of around 2 or less on a scale of 1 to 10. Now, having said that, even when I tell my adults, I mean, you can't really have completely zero pain, I think, after you had surgery, especially if you have a painful surgery. So, I mean, we have to understand that. We have to talk to parents that we have to hold their hands a bit. We have to console the child and do what we can. But, certainly a child should not have untreated pain and shouldn't leave the OR with significant pain. I mean, not the OR, the PACU with significant pain. The mainstay of treatment is IV opioids. Now, Dilaudid or fentanyl or morphine. I use morphine a lot for PACU patients, pediatric PACU patients, 0.05 to 0.1 milligram per kilogram, something like that. And then some people use fentanyl, but opioids is the mainstay of treatment of pain. Now, always titrate the opioids so you don't give too much, and NSAIDs complement opioids. So think about Toradol, and if the patient had Toradol, it can spare you giving a lot of opioids in the recovery room. Respiratory rate is a fairly reasonable guide to opioid effect. In other words, if you have patients with not breathing well or breathing very slowly, you probably do not want to give too much opioid after that. I mean, even if this patient looks like he's in pain, if the patient is very sedated or or breathing very slowly, you should say, well, you should not immediately jump to treating pain. So it's a judgment call on your part. Okay. Acute pain service is available. Dr. Charles Louis and his merry band of nurses. So they are resources. They can be called and they can come and help you. Nausea and vomiting, this is very basic. We try and treat all our patients preemptively with something to prevent nausea. We use Zofran a lot, but virtually all antiemetics work. Decadron and Zofran has been shown to be fairly effective, and this is kind of our mainstay treatment here. Certain pediatric surgeries have high incidence of nausea vomiting, and I think you should know that. Tonsillectomy makes sense. Adenoidectomy, tonsillectomy. Strabismus surgery, because when you pull the extraocular muscles, it can cause you to have more nausea. Mastoid surgery also. So if you have a patient that is coming in from having these surgeries, you should be alert for that, and certainly give something to prevent it. Now, recovery. You use Aldrete scores, is that right? Yeah. And I'm not going to talk about that here. The activity, that's based on activity, respiration, circulation, consciousness, and color. There's another score which my old boss in Children's Hospital and used and wrote as 3 basic criteria, and it kind of makes inherent sense. If this patient is very conscious, he's probably getting more awake. If the airway and return of airway reflexes is back, it's probably ready for discharge. And if the patient is moving purposefully, it's probably ready for discharge. I mean, all these things and he made a score based on these criteria. Now, I think to end off, we want to talk a bit about in Cedars. Who do you call for help if you have problems? Okay, I mean, when you're during the middle busy day, there's a lot of people around, and just calling the most experienced nurse is a big help. But if I were to ask you, after everyone's gone home, who to call, then you may not know. Okay, first one person call if any pediatric anesthesiologist, and if that attending is here, call him or her. And if you have doubts this patient is maybe if you are not comfortable with this patient, ask the anesthesiologist to stay a little bit. Okay, certainly call for the pediatric anesthesiologist to help first. Any attending anesthesiologist should be able to at least manage problems, pediatric problems, at least initially, airway, fluid, bolus, whatever. Okay, anesthesia resident, 1392. Call the resident. If we're not available and attending anesthesiologist is not available, call the resident, 1392. 1393 is available too, anesthesia fellow. Now the fellow, it may not be a pediatric fellow, but it's, it may be the most qualified person that can help you. So you're allowed to call him or her. Now, there's also a rapid response team in that's headed by the PU. I think the PICU intensivists. They are around. Their primary responsibility is the peds ward. But if you need to call them, you can call them. I mean, they're not going to say no. They don't hover and check on you guys. But if for some reason you can't reach anyone, they are available and they'll come. And their team is made up of the PICU nurse and PICU attending, I believe. Yes. And of the surgeon, if the surgeon's still around, ask the surgeon to help. Okay. The anesthesia resident, anesthesia fellow are in-house 24 hours. Now, after hours emergency airway, now airway call. Now, this is not just problems related to the patient per se. You had questions, but the initial slide. This slide has to do with airway emergencies that may or may not be in the PACU, but I'm including here because this is what we tell our residents, this is what we tell the floor. Say in PICU, or say even in your floor or in PACU, you have an airway emergency. By that I mean, someone that you can't ventilate, or you need emergency intubation. The first call is the 1392, the anesthesia resident. Okay. At one point we thought maybe 689, but then if you can imagine it, sometimes midday 689 had so much stuff, and that's the triage nurse. So much stuff and maybe can't help you right away. So actually the most qualified person is probably, or at least the person who knows what the resources are, is the resident, and he or she can either come him or herself to help you, or can relieve some attending, can relieve someone in the room, say, oh, they need your help, and can certainly send someone to help you right away. And after that, 689 can help you too, which is the triage nurse. Now, some last minute, some last words. First of all, has everyone understood the lecture so far? I know we went in pretty fast speed. I would like to issue some challenges to this group. We certainly want to continue the good relationships that we've had, MD nursing collaboration, collaborative-wise. Okay, I mean, I've had really good relationships with many of you, and we want to use it to improve our pediatric PACU. It's not there yet completely, and I think honestly that our pediatric caseload is going to increase. And we might have more pediatric surgeons, and we might be doing more pediatric cases. So we want to continue this dialogue and improve our collaboration. We want to continue helping you improve your curriculum, and this is something I haven't talked to anyone about. But at some point it might be good for the PACU to start knowing what is happening in their practice, in their PACU. So one challenge I want to leave you with is that there's this thing called, in anesthesia at least, significant event reporting. That is, knowing what happens in our practice. Knowing that you had some laryngospasm, or knowing you had, some significant hypotension, or knowing that you needed to re-intubate someone, or something like that. So I'm not going to spend a lot of time, but it would be something to consider to institute some form of reporting and monitoring, so that what happens is then you can come back on a quarterly basis or whatever, and either as a group or maybe with your pediatric champion to say, oh, these incidents happened this week, or this quarter, and maybe teach each other how you treated it, and teach each other what happened, so that all together, you can learn from each other. So that's all I'm saying. Okay. All right, and that comes to the end of my brief lecture. I hope it was helpful. Thank you. Any questions or no question?
When you say preemie, like ex-preemie, so even if they're like 6 years old coming for surgery, you would still consider some of the parameters.
Yeah, okay.
That you included?
6 years old, probably not. Well, okay, let's put it this way. You may not have the apnea, but you have other problems. You may have other problems. Apnea, the older you are, the less apnea you have. And I would say past infancy, certainly past the infant period, you should not have apnea. Okay? But some patients maybe do have lingering CNS problems. For example, that predispose to apnea. For example, say you have this former preemie who has severe intracerebral hemorrhage and kind of have devastated mentally. Certainly those patients, even they're way past, they could be 3 or 4 years old, but still be on apnea monitor at home, maybe. So I think you have to put the whole picture together, depending on the concomitant comorbidity, the other problems that are related. But a healthy 6-year-old ex-preemie, shouldn't have any, can be done as outpatient. It really depends on the other problems related to it. For instance, you may have a child who is 3 years old or 6 years old who doesn't have any, who was a former preemie, even a former micropreemie. Maybe he was 24 weeks when he was born, 25 weeks when he was born, but now it's 6 years old and doing pretty well, but has lingering chronic lung disease. And chronic lung disease manifests in the OR and the PACU as like kind of like reactive airways, so to speak. So maybe those kind of patients, maybe if they had a cold, you wouldn't want to do it. Or say, if you are intubated, you may consider giving patient albuterol treatment in the PACU or something like that. But as far as apnea is concerned, 6-year-old, you shouldn't need to worry about that. Any other questions? All right, thank you.
Thank you, Dr. Chen.